Welcome, curious minds, to vpod.ai. We're diving deep today into a really complex and often puzzling medical condition, one that impacts lives significantly. And this deep dive is brought to you by Stonefly. They're your trusted solution provider and advisor in enterprise storage, backup disaster recovery, hyper-converged VMware, Hyper-V, Proxmox cluster, AI servers, SA365, a turnkey security appliance, public and private cloud. You can check out stonefly.com for more info. So today we're taking on calciphylaxis. It's rare, serious, and frankly, a devastating disease. It presents some unique challenges for diagnosis and treatment. You might not have even heard of it before, but its impact is profound. Especially, for those dealing with kidney disease, think of it like a critical system error in the body's micronetwork, one that's incredibly difficult to debug.
That's right. Calciphylaxis involves this, mysterious and destructive buildup of calcium. And not just anywhere, but specifically within the delicate infrastructure of the small blood vessels, the ones supplying fat tissues and skin. It's often associated with these incredibly painful open sores, and as we'll explore, it carries a really high mortality rate, makes it one of the most serious complications for its sufferers.
Yeah, absolutely. So our mission today is to unpack the most important nuggets of knowledge from, well, a whole stack of sources, clinical overviews, case studies, comprehensive research. We'll explore what it is, who is at risk, why it's so challenging to understand, and what the current state of treatment and research looks like. Think of this as your shortcut to being well-informed on a critical, yet often overlooked, medical mystery. Okay, let's unpack this. How does a system as complex as the human body even develop such a peculiar and aggressive malfunction, I would say? Unpacking the mystery. What is calciphylaxis? So let's start with the basics. When you hear calcification, your mind might go to something relatively common, right? Like plaque in arteries or maybe even bone spurs, something that builds up over time. But calciphylaxis is something far more serious, more aggressive, and fundamentally different from typical calcium deposits. It's not just a benign accumulation, is it?
Indeed, it's anything but benign. It's a rare, severe disease involving the pathological buildup of calcium, specifically within the tiny, delicate walls of the small blood vessels, the ones that supply fat tissues and skin. This isn't just a simple mineral deposit sitting there. It's actually a systemic process where the vessel walls themselves undergo this kind of transformative calcification. Yeah, imagine the body's microvascular system, its intricate network of tiny pipelines, being slowly but aggressively turned into a rigid, brittle material. This hardening leads to, catastrophic consequences for the tissue they supply because blood flow gets severely restricted. It's almost like data packets unable to reach their destination because of a corrupted network cable.
And it has a few different names, right? It sounds like the medical community has kind of grappled with understanding and labeling it, maybe reflecting its complex nature.
Yes, that's a good point. It's also widely known as calcific uremic arteriopathy, or CUA, and that name really helps us understand its core identity. Calcific points to the calcium deposits, obviously. Uremic often links it to kidney failure, where toxins build up, though not always, as we'll discuss. And arteriopathy clearly indicates it's a disease affecting the arterioles, those very smallest arteries.
Okay.
So this precise naming highlights its nature as a vascular disease, specifically attacking the infrastructure of these tiny blood vessels, leading to serious complications from reduced blood flow. Classification systems like Wikidata clearly categorize it as a human disease, a subclass of calcinosis, and importantly, both a systemic and a vascular disease.
Systemic and vascular, that's key.
Exactly. It emphasizes its widespread impact throughout the body and its direct attack on the blood vessel network. It's crucial because it's not simply an accumulation of calcium, but an active pathological transformation of the vascular tissue itself, almost as if the blood vessels are, trying to turn into bone.
That's a truly startling biological malfunction. Now, this isn't just about internal changes. It manifests in very visible and often excruciatingly painful ways on the skin. It sounds like the outward signs are truly distressing, a clear external indicator of a severe internal system failure.
The pain is, without a doubt, one of its most defining and most challenging features. It's characteristically severe, often described by patients and clinicians alike as, unrelenting and excruciating.
Wow.
And what's particularly frustrating is that this intense pain can even precede the appearance of the visible skin lesions. It makes early diagnosis challenging based on appearance alone.
Right, so the pain comes first sometimes.
Often, yes. And because this pain stems from ischemia, essentially, a critical lack of blood flow and oxygen to the tissues, much like a network segment losing power, it tends to be quite refractory.
Meaning resistant to painkillers.
Stubbornly resistant, yes, to typical pain medications, including even strong opioids. This makes pain management one of the most critical and difficult aspects of caring for someone with calciphylaxis. It requires really specialized strategies.
Okay, so what are the early signs you might see then? Before it progresses to those more severe stages, what are those first visual cues that something is terribly wrong?
Initially, you might observe these large net-like patterns on the skin. They can look purple-pink in color. Medically, they're described as livedoid patterns or mottling. It's a direct visual indication of compromised blood flow in the underlying microvessels.
Okay, modeling.
Right. And beyond these patterns, deep, painful lumps can also develop under the skin. These are sometimes mistaken for other conditions initially. As the condition advances, these early signs can then progress to what's known as retiform purpura.
Retiform purpura.
Yeah, they're irregular, branching, often purplish patches caused by bleeding into the skin due to the damage and failing vessels. It's a visible signal of blood pooling and tissue distress.
As we dig deeper into this progression, the implications become incredibly stark, don't they? It sounds like these early signs are just the beginning of a truly devastating cascade. What happens as it progresses from those initial patterns?
Well, as the condition advances, those purpuric lesions can tragically evolve into black eschars,
Eschars.
like scabs.
More than scabs. They're areas of completely dead tissue that form a thick, black, leathery crust. Imagine a system where components are not just failing, but completely dying off. In later stages, these eschars turn into necrotic, ulcerated, and often malodorous plaques or nodules.
Oh, wow.
They frequently develop a gangrenous, sclerotic appearance, meaning they become hardened, dark, and resemble gangrene due to extensive tissue death and hardening. And importantly, these ulcers are notorious for not healing on their own. They become chronic, open wounds, a constant source of agony and risk.
Where do they usually appear? They tend to appear most frequently in areas with high fat content. Think stomach, thighs, buttocks, and breasts. Areas where the underlying microvessels seem particularly susceptible to this calcific assault. However, it's crucial to understand they can form anywhere on the body, including the lower extremities. Really reflects the systemic nature of the disease.
So it starts on the skin, but does it stay there? Or does this systemic nature mean it can affect other parts of the body too? Does this system error cascade throughout the entire biological network?
Unfortunately, no, it does not stay confined to the skin. That's a critical point. While the skin manifestations are the most prominent, visible, and certainly the most painful aspect, calciphylaxis can involve vascular calcifications in a wide range of other tissues and organs.
Like where?
Skeletal muscle, which can severely impact mobility and strength. The intestinal tract, leading to serious digestive issues. The brain, with potential for neurological complications. The heart, compromising its ability to pump blood efficiently. The lungs, affecting respiration. Even the eyes, potentially impairing vision. And the mesentery, that's the tissue holding the intestines in place, which can lead to potential bowel ischemia.
Goodness.
Yeah. This widespread involvement powerfully underlines that it's a truly systemic condition, not just a skin-deep problem. It's a full-body microvascular crisis where the entire network of tiny blood vessels is at risk, leading to cascading failures throughout the system. 2, who is at risk and why is it so puzzling?
Okay, so while it's clearly a systemic disease, it has this very strong association with a particular group of patients, doesn't it? This kidney connection seems to be one of the most consistent factors, almost like a specific vulnerability in the system that allows this error to propagate.
Absolutely. Calciphylaxis most often and tragically affects people with kidney failure, particularly those undergoing chronic dialysis. It's a severe complication within this patient population, almost an Achilles heel for them.
Right.
Studies consistently report an annual incidence of about 1% to 4%, specifically in patients with end-stage renal disease, or ESRD, who are on dialysis. So that makes it a significant and dreaded concern for nephrologists and their patients. It's far more common in this group than in the general population.
But I also read that it's not exclusively limited to that group. Sometimes people with seemingly normal kidney function can develop it, which adds another layer to its mystery. It's like finding a rare bug in a system that otherwise appears perfectly healthy.
That's a very keen observation, and you're absolutely correct. Well, the vast majority of cases fall under what's called uremic calciphylaxis, meaning it's associated with kidney failure. It's also reported in patients with earlier stages of chronic kidney disease. And, more puzzlingly, even in individuals with normal renal function. Yes. These rarer cases are termed non-uremic calciphylaxis. It's an important distinction, however, because the prognosis for non-uremic cases tends to be a bit better. And the lesions typically appear in distal areas like the forearms or feet, rather than the more severe, widespread proximal lesions often seen in uremic cases, like on the torso.
Interesting.
Yeah, it's just different pathways or perhaps different triggers might be at play.
So what's the mystery here then? If it's not exclusively tied to kidney failure, why are kidney patients at such higher risk? What is it about dialysis or advanced kidney disease that seems to be a major contributing factor? What lowers their system defenses?
That's precisely the puzzling part, the fundamental why that researchers are still trying to really unravel. The exact reason why people with kidney failure or on dialysis are at such a significantly higher risk isn't fully clear. But we have strong hypotheses. The prevailing belief is that it's profoundly linked to the severe imbalances in calcium and phosphorus metabolism that are often seen in these patients.
Ah, the mineral balance.
Right. Think of the kidneys as the body's sophisticated filtration and regulation system, constantly balancing these crucial minerals. When this system fails, this delicate balance is just thrown into disarray, leading to an overload or misdirection of minerals, creating a fertile ground for this pathological calcification to begin, almost like a faulty algorithm causing minerals to deposit where they shouldn't.
So the precise cause remains elusive, a deeply embedded bug. But what do we understand about the underlying mechanisms? How does this pathological calcium buildup actually happen on a cellular level, turning blood vessels into bone-like structures?
Well, the core issue, as we discussed, is this calcium buildup in the smallest arteries of fat tissues and skin. Pathologically, it's characterized by systemic calcification of the middle membrane of arterioles. This calcification leads directly to ischemia, that critical lack of blood supply, and subsequently subcutaneous necrosis, which is the death of fat tissue beneath the skin. It's a process where arteries, which should be flexible conduits, become hardened and narrowed, like a water pipe slowly filling with concrete.
But it's not just calcium overload.
Not quite. It's far more complex than just, too much calcium circulating in the blood, which then simply precipitates out into the tissues. It involves a delicate imbalance between the body's natural inhibitors and promoters of calcification. Think of them as built-in safeguards or maybe like antivirus software.
Okay.
Key inhibitors like FETCH1A and matrix gliaprotein or MGP, which is supposed to prevent abnormal calcification, are often found to be downregulated, significantly reduced in patients with calciphylaxis.
So the body's defenses are down.
Essentially, yes. The body's natural defenses against this erroneous calcification are severely weakened. Furthermore, the process itself involves this remarkable and, frankly, concerning cellular transformation. Vascular smooth muscle cells in the arteries, normally responsible for regulating blood vessel tone and blood pressure, actually convert into bone or chondrocyte-like cells, cartilage-producing cells.
They convert.
Yes. These transformed cells then begin to deposit collagen, and crucially, they bind calcium and phosphorus to form matrix vesicles. These vesicles then initiate the mineralization process, ultimately leading to the formation of hydroxyapatite, which is the main mineral component of bone.
That's unbelievable cellular misprogramming.
It is. It's like a software component designed for fluid dynamics suddenly deciding to build a static, rigid structure within itself.
Wow. And what about the parathyroid glands? They're often mentioned in discussions about calcium regulation and kidney disease. What role did they play in this complex equation, like a faulty control system?
Yes. For some patients, the calcium buildup is indeed linked to overactive parathyroid glands. These small glands in the neck are key regulators of calcium and phosphorus. When they become overactive, they release too many parathyroid hormones, PTH, which can disrupt this delicate balance and potentially cause calcium to collect in tissues.
But it's not always the case.
Exactly. This link isn't universally clear, which adds another layer to the puzzle. Many people with severely overactive parathyroid glands don't get calciphylaxis. And conversely, many people with calciphylaxis don't have severely overactive parathyroid glands. It's not a simple one-to-one cause and effect switch. That said, poor control of what's called chronic kidney disease mineral and bone disorder, or CKD-MBD, which often involves persistently high PTH levels and sometimes high doses of vitamin D given therapeutically, can directly or indirectly cause this ectopic or abnormal calcification. So it's definitely one piece of a much larger, complex system failure.
Beyond these mineral imbalances and cellular misprogramming, what are some other factors that seem to play a role? It sounds like it's a multifactorial problem, like several different system vulnerabilities all converging.
You're absolutely right. It's a confluence of factors. One is a greater tendency for blood to clot a hypercoagulable state.
Why is that important?
Well, these tiny clots can form within the already compromised vessels, further depriving tissues of vital oxygen and nourishment, leading to the ischemic damage we discussed, like microblockages disrupting data flow.
Right.
Reduced blood flow in the small arteries due to other factors, along with thickening or scarring of tissue, fibrosis also contribute.
Hmm.
Fibrosis is like scar tissue choking off pathways, making vessels even more rigid.
Okay.
Furthermore, ongoing damage to the thin lining of blood vessels, what's called vascular endothelial injury, is implicated. Think of it as corrosion or damage to the internal cabling. And, importantly, systemic inflammation, widespread inflammation throughout the body is another factor. It potentially promotes the very processes that lead to vascular calcification, almost like pervasive background noise disrupting normal operations and accelerating the error.
So it's not just kidney disease. It sounds like it's a combination of different characteristics and conditions that, when present, can significantly increase someone's risk. What does that multifaceted picture look like? Like a set of preconditions for this devastating system failure?
A clearer picture definitely emerges from various studies, pointing to a convergence of factors that heighten risk. First, demographics play a role, though the exact reasons aren't fully understood. Being born female is a recognized risk factor. Some reports show a 2 to 3 to 1 female predominance.
Interesting.
Caucasian ethnicity also shows a higher prevalence compared to non-Caucasians, and it's most commonly reported in individuals in their 50s, though it can tragically occur at any age. The why behind these demographic differences is still being investigated. Next, comorbidities are highly significant. They act as compounding vulnerabilities. Obesity is a major risk factor, particularly for lesions on the trunk and thighs.
Why obesity?
Well, the expansion of subcutaneous fat can actually increase tensile stress on the dermal arterioles, further reducing local blood flow in vessels that might already be calcified, like a physical stressor, pinching damaged cables.
Yeah.
Diabetes, mellitus, and liver failure are also frequently reported comorbidities.
Mm-hmm.
And autoimmune conditions like lupus or antiphospholipid antibody syndrome have also been implicated. Suggests a potential role for autoimmunity where the body's defenses might mistakenly contribute to the damage.
Okay.
Then we have hypercoagulable conditions. That greater tendency for blood to clot, whether it's hereditary or acquired, can significantly predispose patients. Those small clots exacerbating the ischemia. A patient's dialysis history is also a consideration. While not entirely consistent across all studies, a longer duration of dialysis, especially over 6-7 years, has been reported as a risk factor, maybe linked to prolonged exposure to mineral imbalances or other dialysis factors. Mineral imbalance is often seen calcium, phosphate, or low albumin. Hypoalbuminemia, low albumin, is frequently reported, though it might be more of a marker of malnutrition or chronic inflammation rather than a direct cause itself, indicating broader system distress.
And the levels might look normal in blood tests?
Yes. Interestingly, serum calcium and phosphorus levels might appear relatively normal or even low at diagnosis, which can be misleading. This is likely because the minerals have already been actively deposited into the tissues diverted from the bloodstream, so the lab values aren't telling the whole story at that moment.
Got it.
Finally, medications are a critical factor, sometimes acting as inadvertent triggers. Certain medicines are strongly associated with increased risk.
Like which ones?
Notably, warfarin. It's a vitamin K antagonist. Warfarin can inhibit important calcification inhibitors like matrix glycoprotein, essentially disarming the body's natural software safeguards. Calcium-binding agents, corticosteroids, active vitamin D preparations, even iron therapy have all been linked to increased risk. Furthermore, trauma related to subcutaneous injections, like for insulin or heparin, can also serve as a local trigger.
Like the injection itself?
Yes, potentially causing localized vascular endothelial injury at the injection site, creating a vulnerability. It's why careful rotation of injection sites is often recommended. 3. The devastating impact. Complications and prognosis.
We've touched on the pain several times now, but it sounds like it's more than just discomfort. It's a hallmark of the disease and affects patients so deeply. Can you elaborate on the severity and nature of this pain?
It's a critical point that really cannot be overstated. The pain in calciphylaxis is characteristically severe and unrelenting, often described as excruciating by both patients and clinicians. It's not a dull ache. Patients describe it as a deep, burning torment, like acid seeping into their tissues. A constant, unresolvable system alarm.
That sounds unbearable.
It truly is. And what's particularly challenging, as we mentioned, is that this intense pain can even precede the visible skin lesions,
Yeah.
making early identification difficult. And because of its ischemic origin pain from inadequate blood supply, it tends to be relatively refractory to treatment with opioids, difficult to alleviate with standard pain meds.
So even strong painkillers might not work well.
Often they don't provide adequate relief, unfortunately. This singular feature makes pain management one of the most challenging aspects of care. Requires a highly specialized, often multimodal approach. Standard protocols often just aren't enough. It truly degrades quality of life on a fundamental level.
So these ulcers that form then, they're not just painful, they're incredibly dangerous. This is where the condition becomes truly life-threatening, moving from a localized system error to a full-blown security breach, essentially.
Precisely. The large, deep ulcers that develop are not merely cosmetic or painful. They are critically prone to infection. And these infections are, unfortunately, life-threatening. Sepsis, that severe whole-body response to infection caused by secondary bacterial infection of these ischemic wounds, is unequivocally the leading cause of death in calciphylaxis patients.
Sepsis. The body attacking itself.
In a way, yes. It's when the immune system goes into overdrive fighting an infection, but ends up damaging its own organs in a dangerous runaway process,
Yeah.
a full-body crisis. The UK Calciphylaxis study, a significant registry study, reported bacteremia bacteria in the bloodstream in a substantial 26% of patients.
Wow, 1 in 4.
Exactly. That statistic alone underscores the immense risk. Therefore, finding and treating any infections early and aggressively is absolutely key to preventing these serious, often fatal complications. It's a race against time to contain the breach before it becomes irreversible system-wide damage.
This sounds like a condition with a very, very poor prognosis. The severity and complications point to a grim outlook for those affected, almost like a terminal system failure.
It is indeed. The outlook for people diagnosed with calciphylaxis is, unfortunately, often not hopeful, reflecting the disease's aggressive nature and systemic impact. Literature reports average survival time can be as short as a devastating 2.64 months from diagnosis.
Months.
Yes. Though other data suggest a median survival of about 1 year after the appearance of the skin lesions. When we look at mortality rates, the picture is stark. Estimated to be 30% at 6 months, 50% at 12 months, and as high as 80% at 2 years.
80% mortality at 2 years.
It's incredibly high.
Mm-hmm.
To put that in perspective, 8 out of 10 patients may not survive 2 years post-diagnosis. The UK Calciphylaxis study found an astonishingly high mortality rate of 72 deaths per 100 patient years, with a median survival time in their overall cohort of just 4 months.
Just 4 months median survival in that study?
Yes. These numbers are a stark reminder of the condition's severity. It indicates a disease with one of the poorest prognoses in medicine.
That's a devastating difference compared to matched patients without the condition. It highlights just how profoundly calciphylaxis impacts survival, a clear and independent risk factor for system failure.
Absolutely. A comparative analysis within that UK study clearly demonstrated that the presence of calciphylaxis was a strong and independent risk factor for all-cause mortality. The annual mortality rate for patients with calciphylaxis was a staggering 67%. Compare that to only 10.2% in matched hemodialysis patients without the condition.
Wow, nearly 7 times the risk.
Exactly. It makes it one of the most lethal complications of kidney disease. And beyond mortality, the condition also severely impacts quality of life, leading to chronic, debilitating pain, significant depression, persistent insomnia, all of which further compromise overall well-being and ability to function.
It must be isolating.
Extremely. More than half of patients can become bedridden or require a wheelchair due to the relentless pain, the size and location of the large ulcers, and just overall physical debilitation. Imagine losing your independence and mobility almost entirely, facing a constant battle with pain and psychological distress. It's a profound effect on their daily lives, transforming their reality into one dominated by their illness. 4. The challenge of diagnosis and management.
Given how devastating this condition is, getting a diagnosis quickly must be absolutely critical. How do doctors approach this, especially when the symptoms can be so varied and the exact cause is often unclear? It sounds like a real challenge in clinical pattern recognition.
A high index of clinical suspicion is absolutely paramount for early and accurate diagnosis. Primarily because, as you say, there are currently no universally validated diagnostic criteria for calciphylaxis. It's a diagnosis often made by piecing together a complex clinical picture, almost like debugging a system without a comprehensive diagnostic toolset.
What are the key clues then?
The intense and characteristic pain, combined with palpating that firm, calcified subcutaneous tissue beneath the skin, that's often a very strong indicator, especially when it presents in patients with relevant risk factors like kidney failure or obesity. Clinicians must actively consider calciphylaxis even with subtle initial signs, because delaying diagnosis can have dire, irreversible consequences. Every moment really counts in trying to halt this progression.
And what about a skin biopsy? Is that considered the definitive diagnostic method, or are there nuances and potential pitfalls there too? Almost like a complex forensic analysis.
A skin biopsy is indeed considered the definitive diagnostic method. It allows for direct examination of the tissue changes under a microscope, gives you a clear code analysis of the pathology, so to speak.
What does it show?
Typically, a biopsy will reveal calcification directly within the small dermal and subcutaneous arteries. Alongside microthrombosis, those tiny blood clots, and fibrointimal hyperplasia, which is that distinct thickening and scarring of the inner lining of these vessels, all contributing to the critical ischemia. The biopsy often shows intense septal paniculitis, inflammation of the fat tissue.
And special stains are needed sometimes.
Yes, to highlight subtle microcalcifications that might be missed on routine examination, special calcium stains like von Casa or alizarin red are often needed. They bind to calcium deposits, making them vividly visible, like using specialized software to highlight corrupted data points.
What are the challenges with performing a biopsy, then? It sounds like even a definitive test has its complications, perhaps even exacerbating the issue.
You're right, the biopsy itself, despite being definitive, carries inherent risks that must be carefully weighed. These include localized progression of the disease at the biopsy site, the formation of new ulceration, an increased risk of infection in an already vulnerable area, and potential bleeding.
So it's not without risk.
Not at all. It needs to be performed with extreme care, preferably from the margin of the lesion, not the center of an ulcer, to maximize diagnostic yield and minimize complications. And the specimen then needs to be reviewed by an experienced dermatopathologist, someone with highly specialized expertise in skin diseases and calciphylaxis, to ensure accurate interpretation.
And sometimes it's still negative.
Sometimes, yes. Even with careful measures, biopsies can be non-diagnostic or falsely negative. Maybe the calcification is subtle, or the biopsy didn't capture the specific affected area, or just sampling error, like a diagnostic scan missing the true core of the problem. In such critical cases, if clinical suspicion remains high based on the patient's severe symptoms and risk factors, treatment may very well be initiated based on a presumptive diagnosis, rather than waiting for a delayed or inconclusive biopsy result that could cost valuable time.
Are there any lab tests or imaging modalities that help support the diagnosis or assess the extent of the disease, even if they aren't definitive on their own? What kind of system logs or network maps do doctors use?
Yes, laboratory evaluation focuses primarily on assessing potential risk factors and general health. Acts like a review of the system's operational logs. This includes checking serum calcium, phosphorus, alkaline phosphatase, parathyroid hormone, PTH, albumin, C-reactive protein, the central marker of inflammation, liver and kidney function tests, coagulation studies. Other inflammatory markers are also important to get a full picture.
But the calcium levels might look normal.
Right, that counterintuitive point again. At diagnosis, serum calcium and phosphorus might appear relatively normal or even low, because these minerals are actively being deposited into the tissues, not staying in the bloodstream. The blood test isn't reflecting the total calcium burden.
What about imaging?
Plain X-rays, CT scans, and nuclear bone scans can all show evidence of calcification in the soft tissues. Bone scans, in particular, have shown high sensitivity, up to 97%, for detecting abnormal calcium deposition in the subcutaneous tissue of lesions. Makes them quite valuable for confirming the presence and extent of calcification, almost like a heat map showing areas of high abnormal activity.
But no single imaging test is definitive.
Correct. There isn't one single standardized, reproducible imaging modality that provides a definitive diagnosis on its own. They're best used in conjunction with strong clinical suspicion and, ideally, a targeted biopsy.
So once a diagnosis is suspected or confirmed, what's the treatment strategy? Is there a standard, universally accepted protocol, or is it more complex given the rarity and severity? Sounds like a major incident response with no single playbook.
Given the extreme complexity and rarity, you're absolutely right. There's currently no single, formalized treatment algorithm or definitive randomized controlled trial to guide care. This means management is highly multifactorial and absolutely requires a dedicated, multidisciplinary team effort.
A whole team.
Yes. Specialists from various fields are critical partners, almost like a cross-functional incident response team. nephrology for kidney disease and mineral balance, dermatology for the skin lesions, dedicated wound care teams, pain management specialists, plastic surgery for debridement or grafting, and nutritionists to address the frequent malnutrition. This collaborative approach is essential because no single intervention is usually sufficient to tackle the myriad of problems calciphylaxis presents.
What are the main areas of focus for treatment, then, in this multidisciplinary approach? How do they begin to tackle such a complex and aggressive system failure?
The main areas of focus are comprehensive, addressing various critical aspects, aiming to stabilize the system and mitigate the damage. First, wound care is absolutely paramount. Primary goals: prevent infection, the leading cause of death, and facilitate healing of the painful ulcers.
How's that done?
It involves specialized dressings, sometimes chemical debridement to gently remove dead tissue. Surgical debridement, though controversial for non-infected stable lesions, may be considered for large necrotic areas or severe infection to clear things out. Negative pressure wound therapy, which helps draw fluid and promote healing tissue, and sometimes skin grafting are also employed. And importantly, a low threshold for initiating broad-spectrum antibiotics is highly recommended at the first sign of infection due to that high sepsis risk.
Okay.
Second, pain management is critical. Because the pain is so severe, it frequently requires strong analgesics, often a combination. A multimodal analgesia approach combining opioids with non-opioid adjuvants like nerve pain meds, sometimes even ketamine, is often necessary. Pain medicine and palliative care teams are critical here.
Makes sense.
Third, addressing underlying factors, particularly CKD mineral and bone disorder, CKD-MBD. This is a core responsibility for nephrologists. Goal is to optimize calcium and phosphorus balance, maintain serum levels in the normal range, meticulously avoiding calcium supplements and high dialysate calcium.
What about phosphate binders?
Non-calcium-based phosphate binders like sevelamer or lanthanum carbonate are generally preferred over calcium-containing ones to avoid adding to the calcium burden. For secondary hyperparathyroidism, cinacalcet, which lowers PTH, is often preferred over vitamin D analogs, especially if there's hypercalcemia or hyperphosphatemia.
And surgery.
Parathyroidectomy.
Yes, that's an option. Surgical removal of the parathyroid glands. It's considered for secondary hyperparathyroidism that's refractory, unresponsive to medical therapy, especially if PTH levels are persistently way high, like above 800 pgml for over 6 months.
That doesn't help.
Observational studies have associated it with significant improvement in survival rates, maybe 15% up to 57%, plus better control of minerals, bone density, quality of life. But it also carries surgical risks and potential post-op complications like hungry bone syndrome.
Hungry bone syndrome.
Yeah, where there's a profound sudden drop in calcium and phosphorus levels after the glands are removed. Requires intensive monitoring and calcium supplementation. It's a major hardware intervention with its own challenges. Got it. What else?
Fourth, dialysis optimization. Ensuring adequate dialysis is crucial to manage kidney failure and reduce uremic toxins. However, routine intensification of dialysis beyond established adequacy goals isn't typically recommended without strong data showing benefits specifically for calciphylaxis. Finally, medication review, a vital step. Like auditing the software stack. Discontinuing meds that might contribute warfarin, corticosteroids, iron is carefully considered on a risk-benefit basis. Warfarin is particularly scrutinized.
One treatment I've seen mentioned frequently in the sources is sodium thiosulfate. What's the story there? It seems to be a common intervention, almost like the go-to patch or workaround for this system error, but also one with some significant debate around its efficacy.
Sodium thiosulfate, or SPS, yes. It is probably the most commonly used off-label intervention for calciphylaxis, especially since its first reported use back in 2004. It's become widely adopted given the lack of other truly effective therapies.
How is it supposed to work?
Its proposed mechanisms are quite diverse. It's thought to form water-soluble complexes with calcium, essentially helping to dissolve calcium deposits and remove them, like a chemical solvent clearing unwanted mineral data. Beyond that, it's believed to act as an antioxidant, reducing oxidative stress, and a vasodilator, helping widen blood vessels, potentially improving blood flow. Maybe like optimizing data flow in constricted conduits, it might also have some analgesic properties.
Sounds promising, theoretically.
Exactly. These theoretical benefits made it a very promising candidate, given the disease severity and the desperate need for any viable solution.
So if it's widely used and has these proposed benefits, that must mean it's very effective, right? The widespread adoption implies a strong positive outcome for patients.
This is precisely where the nuanced picture emerges, and it's a critical distinction for understanding the current state of treatment. While many retrospective studies looking back at past patient data have indeed reported resolution or improvement in a significant percentage of patients, some suggesting over 70% remission. And it can sometimes lead to a noticeable improvement in pain within 1 to 2 weeks, which has been noted as a predictor of long-term response.
But there's a but, isn't there? It sounds like the large-scale evidence doesn't quite line up with the anecdotal or early retrospective findings, creating a real paradox for clinicians.
Yes, there's a very significant but here, and it's a point of considerable debate and frustration within the medical community. The largest and most recent meta-analysis, which systematically reviewed 19 retrospective cohort studies encompassing over 400 patients, a substantial amount of data for such a rare condition, concluded that STS treatment does not result in a decrease in skin lesion progression or overall mortality.
Wow, no decrease in progression or mortality.
That's what this large analysis found. It's a powerful and sobering finding that really highlights the limitations of retrospective studies, where controlling for variables and biases is so difficult. It also noted that the impact of STS on pain intensity remains uncertain, despite some individual reports of pain relief. It's like having a software update that seems to fix small individual bugs locally, but large-scale monitoring reveals it doesn't actually improve overall system stability or prevent critical, fatal failures.
That's a critical distinction. So if a large meta-analysis suggests no significant benefit for progression or mortality, why is it still used so frequently in practice? What's the rationale? It highlights the desperate need for better answers.
Well, despite those findings from the meta-analysis, its use is still often considered justifiable by clinicians. This is primarily due to the severe morbidity and the devastating mortality linked to calciphylaxis itself, and the stark reality of the lack of other definitively proven effective treatments supported by high-quality randomized controlled trials.
So it's used because there's little else.
Essentially, yes. In the face of such a dire condition, where options are so limited and the prognosis is so grim, even a potentially modest or unproven benefit, coupled with a relatively good safety profile, makes STS seem like a viable option when there's little else available. It's a therapeutic choice often made out of necessity and compassion in a truly desperate situation.
How is it given?
Typically intravenously, commonly 25 grams for hemodialysis patients, usually during the last half hour of their dialysis session. For peritoneal dialysis patients, it can sometimes be administered intraperitoneally, though that route carries the specific risk of chemical peritonitis. Inflammation of the abdominal lining adds another risk.
Are there any other promising treatments that have been explored or are on the horizon given the current limitations? What are the next generation solutions being explored to tackle this systemic failure?
A number of other treatments have indeed been explored, often in smaller studies or case reports, showing varying degrees of potential. These include bisphosphonates, usually used for bone conditions but may inhibit calcification, low-dose tissue plasminogen activator, which breaks down clots, LDL apheresis, removing LDL cholesterol but maybe broader vascular effects, and even vitamin K supplementation, given its role in activating calcification inhibitors.
What about transplants?
Kidney transplantation has also been considered as a potential intervention, particularly as it resolves the underlying kidney failure that is so often a trigger. These are generally evaluated on a case-by-case basis, considering their significant costs, availability, and the specific patient's complex profile.
It certainly sounds like the medical community is still actively seeking definitive answers and more effective treatments for calciphylaxis. This isn't a solved mystery. It's an ongoing, complex debugging process.
Indeed. A major limitation in advancing treatment is the absence of large, randomized controlled trials. They're just inherently difficult to conduct for rare and severe conditions like this. Patient numbers are small, ethical considerations of withholding potential therapies in a placebo arm are complex. It's hard to gather enough statistically significant data.
But research is ongoing.
Oh yes, very much so. With promising clinical trials investigating various approaches, more rigorous studies on STS, examining vitamin K supplementation, exploring novel inhibitors like SNF472.
SNF472.
Yes, it specifically aims to inhibit hydroxyapatite crystal formation, the very mineral that calcifies the vessels. The path forward involves continued basic science research to understand the pathophysiology beyond just the bone mineral axis, and critically, fostering collaborative multi-institution studies and registries. This type of collaborative effort, sharing data and insights across centers, is crucial to gather more robust data for evidence-based diagnostic criteria and, most importantly, for developing truly effective treatment guidelines. It's really a global effort to solve a biological riddle. Outro.
Wow. This deep dive into calciphylaxis has truly shown us a condition that is just as complex as it is devastating. From its mysterious origins and the perplexing ways it impacts the body's micronetwork to the immense challenges in diagnosis and treatment, it's clear there's still so much to learn and so much hope resting on ongoing research and collaboration.
It really is a testament to the resilience of patients who endure such excruciating pain and severe complications, and to the dedication of medical professionals grappling with a condition that demands such a comprehensive, compassionate, and continually evolving approach. Understanding its intricate details, even in this current state of uncertainty, empowers us all. To be better informed and appreciate the frontiers of medical discovery, it's a reminder that even in the face of the most complex system failures, the human spirit for innovation and healing persists.
It certainly does. A powerful reminder. And on that note, we want to thank you for joining us on this deep dive into calciphylaxis. Before we go, a final word from our sponsor. Don't forget to check out the Stonefly 100 TB Immutable and Air-Gapped SSO NAS, available for just $8,995. Join us next time for another deep dive into the information you need to know.